Hi, everyone. Well, you're the lucky ones. You chose this session. You will leave invigorated, full of knowledge, and you'll say to yourself, why does an interventionalist have to know about inflammation? Well, we're here to tell you about it. Let me begin with this disclaimer. Novo Nordisk has organized this. That's why we're so innovative. They manufacture lots of products. We know all about them. Some very, very well known, but they're more than just Ozempic. And they're digging into a new area of inflammation. So we're going to talk about some things. It's important for you to note that as a major disclosure and disclaimer that I am the chair of their Artemis trial. We're going to discuss that today. You're going to leave with a lot of really good information. And I want to make sure, please do not take pictures and disseminate. Some of this stuff is, you got lucky, you got in here. So take it all in. We are targeting inflammation through a debate. And I'm just so very excited with this incredible, my two faculty members, Davide Capodanno and of course Dr. Yukima, Professor Yukima, very well known. We're talking about it through a debate because there is so much to debate about. And I'm going to ask you guys at the end who won and what did we learn. But mute your phones. Get rid of all the interactions from the outside. I want you all in here with me. I want interaction. I want questions. I want you guys to talk to us. That's why we're in this small room. So here's the run of today's meeting. We only have about a very, very short period of time. I'm chairing this with Professor Yukima from Leiden and Professor Capodanno from Catania. I said it's interactive, and I mean it. So here's your chance. Please, I want to see all the cameras up. There's the one place. Because I want you to take it. You submit these questions throughout, and we'll answer, I promise you, proper questions. I'll answer all of them. Improper, no. Scan the code, use the Slido, and we will get it for you. So let's start. Let's make sure you know what you're doing. Is IL-6, does anybody even know what IL-6 is? I hope. It's a cytokine, guys, okay? Is it a viable target in acute setting after a myocardial infarction to prevent future major adverse cardiovascular events or worsening cardiac status? Put it in. Wait, was it that fast?
No, it's fine.
No, I didn't hear the music. Are you guys putting in? You're still putting in? Keep going. Keep going. Keep going. We're going to see the answer soon? Oh, okay. Let's go home.
Okay,
Thank you.
Congratulations.
Well, well, just imagine this has to get better than 96%. So let's see. You know, these are good debaters. But really, I'm going to go through this. They're going to debate their hearts out. It's going to be a lot of fun. And then we will come back to questions. We have a really ample time for Q&A. But let's talk about inflammation. And why would an interventional cardiologist even think about that now? What do we know? My disclosures first. And as I said, I'm the co-chair of the Artemis trial, which is a trial that's being run for ziltivekimab, which is a molecule that Novo Nordisk is developing. It's an IL-6 inhibitor. And it's going to be used in acute myocardial infarction. My interest in residual inflammatory risk goes back 20 years, believe it or not. I've been very interested in this, and I believe that it does have an important impact. In fact, in every single patient of mine who comes to the cath lab, and we've implemented this now at Mount Sinai. I'm at Mount Sinai. I'm an interventional cardiologist there. And we have a prospective database, and we measure C-reactive protein in everyone. How many of you measure C-reactive protein in this room? Oh, these are really enthusiasts. Excellent. I love it. So let's start with a clinical case. Something we will see almost every day. 72-year-old woman who comes in with a recurrent MI. Take a look at her history. This is not, and I chose a woman because women do get recurrent events, and we need to take care of them. She's obese. BMI is 34 kilograms per meter squared. She has type 2 diabetes. She's on metformin, on really good therapy, GLP-1 receptor agonist. She's hypercholesterolemic, and she's on high-dose statin, ezetimibe, and PCSK9 inhibition. She has chronic kidney disease with an estimated GFR of only 47 milliliters per minute, and she has polyvascular disease. I mean, how much more risk do you want for someone with multitudes of risk? But let me take you through her journey. In October of 2021 is when she presented with a non-STEMI and a right coronary artery as her lesion of interest. A DES was placed in that mid-right coronary artery, but at the time, because I measure C-reactive protein, her C-reactive protein was 10 milligrams per deciliter. Anything above 3 is abnormal. Hers was 10, expected, non-STEMI. All kinds of things are happening. She received the DES in the mid-right coronary artery. Look at her LDL cholesterol. She was untreated, 147. Most women are undertreated. Lipid-lowering therapy was started with high-dose rosuvastatin, ezetimibe, and she goes home. A year later, she comes back. Her LDL is doing great, but look at her C-reactive protein. This is a person with residual inflammatory risk. Someone whose C-reactive protein, even in a chronic state, has not gone back to baseline. We added a PCSK9 inhibitor because we have nothing else for that at that time. And we gave her avolocumab to bring that LDL even lower below 80 and probably into the 60s, even less than 55. We stopped that, went to aspirin monotherapy. We worked this through a heart team with our referring cardiologist. Now, you might say, why? Well, if you care so much about inflammation, why didn't you put her on colchicine? It's a really good question. We'll talk about that. The fact is that with chronic kidney disease, many people are nervous about colchicine. We don't have enough data. But also, it's actually not that easy to get in the States. In November of 2023, she comes in with an ER admission, and here it is. Now she has an anterior wall MI. The LAD is down. We put in a DES, mid-LAD, and that's what we have. These things happen. Her LDL cholesterol is now 60, and of course, her C-reactive protein with a STEMI now is at 12. We restarted DAPT. Her risk for a recurrent event after already a second recurrent event is quite high. And these are the strategies. And this is a paper that we wrote based on our data, our experience at Mount Sinai. We are measuring their residual inflammatory risk. And those that have high come in high and they stay high, just like this patient. We know that if you have a persistent high residual inflammatory risk, there is an association with worsening, higher mortality, higher MACE rates. And even if you are in the increased risk, so you were low and then you come back at a high level, you're also at a higher risk compared to high going low or low staying low. So we are working very, very hard. And of course, we care about those traditional risk factors. And we all do, right? You do this. I hope you do this. Every one of this for every patient, every man and every woman who comes in, you're talking to them, diet and lifestyle, smoking, you addressing hypercholesterolemia. In a patient like this, you want that LDL very, very low. Diabetes, of course, needs to be very well managed. And CKD, hypertension, these are all important risk factors. And then there's non-modifiable, the age and, of course, the genetic predisposition. But here's what's coming. The emerging risk factor of inflammation. It's really, we're calling it emerging because we're just talking about it. But it's been around. We've been knowing about this for over 20 years. Paul Ritker, Peter Libby, I followed them since I was a fellow. Don't tell them because they feel like they're a lot younger. But I've been following them, and I really believe in this. And it's this NLRP3 inflammasome. How many of you know what that is? Some, not all. Well, you're going to leave here as masters of inflammation. The NLRP inflammasome is how it all gets started. When there is injury, when there is something different in your body, the cascade starts to go. And those patients who are with high inflammation, the NLRP inflammasome is turned on. And of course, there is tremendous downward cascade of cytokines that come into play. And we know all about that. You start to see with the NLRP inflammasome, you start to see that you begin to have IL-1 beta, IL-6, and that IL-6 is the last one that goes into the liver, and the biomarker that we're measuring out of the liver is the high sensitivity C-reactive protein. Inflammation plays a very pivotal role in atherosclerosis and its development and progression. All of these things with regard what the nidus of turning on that inflammasome could be as small as a cholesterol crystals, neutrophilic extracellular traps, all of these things that come in and have an important impact. And the chronic activation of the inflammasome is pivotal in induction of the inflammatory cytokine cascade. And of course, you heard what I said. But I think what I want you to look at is the vascular risk associated with the different levels of that high sensitivity C-reactive protein. When it goes above 3, now a patient was 6 at its most quiescent. She had 6. So she was constantly inflamed. And the timing of this is really, really important, especially as it pertains to an acute coronary syndrome, a STEMI or a non-STEMI. And this is the area where we're looking to target. We're going after this now because aren't you all tired of the residual risk, the constant recurrent events, and no matter what we're doing, these patients keep coming back. We want to get to the best level, for the best place for our patients. And if you look, in STEMI and non-STEMI, that, especially with PCI, the timing is key. It's very, very early, within 12 hours. And pretty much in that first 24 to 48 hours. Remember this slide. I want this to be in your brain, because if we're going to have all of you become major contributors to the Artemis trial, I hope, you will understand why we're making you address this. The sooner, the better. And you know, inflammation matters no matter what your cholesterol is, even in patients who have a low cholesterol, as my patient did. Her C-reactive protein was still elevated, and high inflammation is what dictates MACE down the line. And in fact, through a registry that we have with 36,000 Danish patients, we are seeing the very important impact association of elevated C-reactive protein, whether it's at 30 days or beyond, out to 365 days, with increasing the absolute risk of death in those patients. It matters. And in fact, if you look at invasive and non-invasive management and strategies in patients with unstable coronary syndromes, you might say, why is it that sometimes we're not getting the impact? If that patient's IL-6, which we hardly ever measure, is greater than 5, well, look what's going on with non-invasive management. So it is really about your invasive management to be coupled with something more than just put a stent in it. It's something more, especially if the patient has high inflammation, which happens in our patients. Which brings us back to this schematic. Think about this schematic. I really want us to think beyond what we're doing in the cath lab and see how can we make our results durable by understanding the cascade of inflammation. Oxidative LDL, cholesterol, deposition in the vessel wall in someone with an MI who has a ruptured plaque, turning on that inflammasome like nobody's business. And what happens? The cascade of pro-inflammatory pathways that are coming down, going to the liver, last one, IL-6, and of course, very important C-reactive protein coming out. We have been, this is not the first time ziltivekimab is going after IL-6. This isn't the first time. Now, the NLRP3 inflammasome has been addressed by using colchicine. So it's not going after that one pathway, it's coming upstream. We have seen some good impact, and we're going to hear a little bit about that. But canakinumab, you all remember the CANTOS trial? The biggest and the most important result of that trial in post-MI patients who happen to have an elevated C-reactive protein in the large numbers. These were post-MI patients, and when they had 2 different dosing of canakinumab, you know that canakinumab at both doses reduced major adverse cardiovascular events by 16% in both of those doses, 150 and 300 milligrams. And very important is the association of looking at IL-6 and that lowering that IL-6 that had a very, very important relationship with reduction of MACE. So this is the subject of, should we go after IL-6? Could this be a possible target? Well, some are in the pro, some are in the con. Well, you see where I stand, but I'll try to be unbiased. I am the chair. I have a lot of biases because we're leading the trial. But we're going to start with Davide Capodanno, but it's important to note his disclosures, and then we're going to go straight in. They're going to debate. I'll try to separate them if it gets really bad. But Dr. Yukima also has his disclosures. And why don't we start with you, Davide? Is IL-6 the right target?
Okay, so for the records, we started with 94% of yes, or more or less, and only 4 to 5% or no. So my task is not to decrease this proportion, because otherwise, so the bar is very high. So the question is clear. So now, of course, as scientists, we are interested in this question, and I think it's a legitimate question. And we, as interventionists, are not very much used to the experimental studies, preclinical models, but I found this experiment interesting. So when you read it, you see that our colleagues who do this kind of experiments are great. So imagine 30 pigs, okay? And they inflate a balloon in their LAD, poor pigs, for 75 minutes. So they induce a myocardial infarction. And infarction in this model, it's in white. While the thing that you see in this specimen in red is the area at risk. So it's the area, it's the territory of the LAD. So essentially, what you are interested in is the ratio between the white and the red. The larger the white, the more the scar. Okay, and the infarction. When you see only red, it means, okay, area at risk, but no infarction. So what they did was to deflate this balloon after 75 minutes. And then what they did was to randomize the pigs, 10, 10, 10, to placebo, or to a low or high dose drug, which is an anti-inflammatory drug, not available for use, but still with an effect on these pathways. So what you can see is that with the higher dose, 6 milligrams per kilogram, you see less white. And the largest area of white is with the control. If you are more a fan of the graph, this is it. So essentially, this anti-inflammatory medication was effective in reducing the area at risk in a way, but also the infarction. So animal, of course, in this case, allow us to have a visual, a display of what is going on. But then, of course, we want to see some science. Then, of course, you look at patients, and this is a meta-analysis of a lot of patients, 30,000 patients with ACS, 13 studies, some of them observational, but this is not a treatment effect meta-analysis. So they are not comparing one drug versus another. They just look at the association between one marker, in this case interleukin-6, and one effect, one outcome, MACE, mortality, cardiovascular death. So it's clear that there is a link. Of course, when you see an association, this doesn't mean that there is a causality. So maybe interleukin-6 is high in these patients just because they are sick. But you can see that the link is very important. MACE, but even more, all-cause mortality, which goes in the direction of the graph that Roxana has shown, and cardiovascular mortality. Now, let's be back as doctors. Now, I think you have seen at the ACC the results of these two important studies, very much awaited, which were neutral. So I don't like to say negative for the study, but neutral. So they didn't show any effect in myocardial infarction for empagliflozin, EMPACT-MI, and for beta blockers in reduce-MI. That's incredible if you think how much important these drugs are in the field of heart failure. But acute MI is another animal where many things fail beyond the usual suspects, revascularization, obviously, and antithrombotic therapy. So my point is that is interleukin-6 the right target in MI? I hope so, but for sure we need to explore this because patients continue to have events and we fail with medications that are supposed to be effective and they are not. So we have to look for something totally different, and inflammation can be this different thing.
Okay, what do you have to say about that?
I think, my friend, you're rather optimistic, which is a good thing.
I'm always optimistic.
First of all, there are many interventionalists that are interested in basic stuff. I've done more than 10,000 PCIs in my life already, but still I have an animal department, so it's a lot of us are interested in this stuff, I think. And if they're not just interested, they should be. But you're also a little bit optimistic, in my opinion. You showed two trials that did not add. And this is why, because actually, if you look over the curves in the 2 decades ago, you see that we did a lot with the primary PCIs and we did a lot with statins. So the in-hospital mortality went down, the 30-day to 1 year. So actually, we did a lot. So it is not that easy to improve on that because, well, we know undifferent chest pain accounts for 5 to 10% of the adults visiting the pre-hospital setting. We have pre-reperfusion administration and we have post-reperfusion administration. Actually, there's not a lot to improve anymore. So it's difficult. It's really difficult to improve. And that's actually what you always see. You say, okay, inflammation is everything. So that's what you argue now, and the chairman also. But look at these commands. This is the guidelines, ESC, ACC, the Latin American guidelines for colchicine, so anti-inflammatory drug. It's only 2B. So you could consider. Nowhere is there, you should do it. And if I do it, I have in 1 minute, I have the pharmacy on the line and say, you're prescribing off-label. Because colchicine is not indicated for treating myocardial infarctions. It's for having your joints inflamed, but not for coronary artery disease. So it's not that, it's probably more difficult than you suggest. There is probably some balance.
Okay.
Here's the balance.
So I'm not supposed to be part of this debate, but I just can't help it. Okay? I just can't because I'm from New York. Look at this. Your date is 2002. Where have you been in the last 20 years?
Doing PCIs. It just told you 10,000 PCIs.
And watching the line be flat with residual events that keep coming and us not making an impact no matter how short we make that door to balloon time, no matter how much antithrombotic regimens we throw on patients, no matter how much statins we give them, we have made zero impact in acute MI. You know that, right? The last decade, and that's the reason why the global burden of cardiovascular disease is actually, its decline is slowing down and in fact increasing, especially for our young patients. So I'll just say that. That's an important... No, sorry, I'll give it back to you. Go back.
No, 2 is better than 1. So
I had to stop
please
it.
help. No, let's say it's always the same story. No, the glass is half full, half empty. I'm optimistic, yes. You are maybe too pessimistic, I think, and I will show you why. So first of all, let's go into the mode of actions, because of course we are talking of patients with a myocardial infarction. The last thing we want is to hurt them, of course. And maybe the question is whether we are going to do something which extinguishing inflammation, in the end, impairs the balance between the good and the bad of inflammation and the ugly, as in this review. So what I want to say is that inflammation is a healing process to some extent, but as you know, when inflammation is exaggerated, it creates a lot of problems. And particularly in the chronic phase, there are patients who have a residual low grade of inflammation, and this is of course something you can measure with the CRP, and these patients have an activation of macrophages, not all the macrophages, but especially the phenotype M1, which is the one responsible for the productions in the end, in the downstream pathway of interleukin-1. And then the high level of interleukin correlate with the high level of interleukin-6. This is what happened in these patients that have recurrent events more and more. They are really in a revolving door, and they are frequent flyer of our hospitals, unfortunately. But what I discovered by liking and looking at this topic is that in the first 4 days, many bad things happen. There is an acute burst of inflammation, which is mediated again by these macrophages type 1, but especially by the neutrophils and the polymorphonucleates. And so the levels of interleukin-1 and the levels of interleukin-6 are even higher. So in this initial phase, I think many of the things will affect the outcomes downstream, not just in terms of atheroprogression, which is for me something that happens in the long run, but think of left ventricular remodeling, think of infarct size, think of MACE. So in the end, what we want is definitely to interrupt somehow, to break this process, and we have to look for ways to do that. The other thing I want to say, Roxana has mentioned, of course, CANTOS. Canakinumab is really the trial that is the proof of concept for what we are discussing now, because the trial was technically positive, okay? You can discuss why the drug is not on the market. There are many reasons that are also financial reasons, not really scientific reasons, and we are discussing science here. What is crucial is that this study is the proof of concept study, because it was powered for major adverse cardiac events. So it's no longer peaks, it's no longer small studies phase 2. This is a large-scale outcome trial, which is what we want to see as doctors to take decisions. Roxana said that the 2 higher doses of canakinumab were better than placebo. There is an important sub-analysis of this study that shows that the effect was clear in those patients who had their level of interleukin-6 abolished. Remember, canakinumab is against interleukin-1. So the question is, if the effect is better in patients who have low levels of interleukin-6, why don't we tackle interleukin-6 directly rather than going upstream? Let's go downstream. So I find the story building up and quite convincing.
Yes, my friend, but I think you're a little bit selective. Let's see this slide. You discuss panel number 2 and panel number 3. Why did you skip panel number 1?
Because it's a debate.
So I will go to panel number 1 for you. And hey, the inflammatory cascade has beneficial protective as well as healing properties, which you kindly did not discuss.
I said
protecting and healing, because in the acute phase you have IL-2 and IL-10, the very important interleukins, and actually what they interact with the T cells, the M2 macrophages, and they are protective. So you have Treg expansion, you have less inflammation. So I do think actually that it is pretty important also to discuss that phase. I don't have the final answer, because if you look at literature, it's poorly understood. We have experimental data, we have clinical data, and post-MI inflammation comprises actually both damaging as well as healing aspects. So I'm not truly convinced that it's all good. So could anti-inflammatory therapy in the end do more harm than good, especially in the acute phase? And I'm a little bit worried about that, because this timing is important, and you did not discuss properly the timing. How should we do that? This is how it works. IL-6 is a pleiotropic cytokine, as I already said, with many beneficial, but also with deleterious effects. Okay, point well taken. And you see how it works in acute phase. That's my point. So you have the IL-6, which activates actually the JAK-STAT pathway. And finally, of course, then you get a suppressor of cytokine signaling, the SOX. And that is good, because then you have preconditioning response. It prevents cardiomyocyte apoptosis, so you are left with more cardiomyocytes, which is also a good thing of mine. So finally, this leads to tissue preservation. So the acute phase we should not overlook. I do think there are beneficial effects, but also potential harmful effects. So check it out. Colcott, well, was it only positive? Lodoco2, also with Colgin, was it only positive? I don't think so, because actually we saw more infections both in Colcott as in Lodoco. We saw more non-cardiovascular death in Lodoco2, more myalgias, more pneumonias. And these trials, during the trial, it was specifically said to the investigators, all of us here present, take care, take care. At the first sign of infection, take care, treat with antibiotics. So it's not completely neutral, so we have to take care.
Okay, so I accept this argument. However,
okay, stop.
However, so everything is recorded, so you will see that I said that the inflammation was a positive effect, but you're right. There are pros and cons in things. Well, the issue is I don't know any drug that does no side effect. So if we are talking of a acute myocardial infarction, think of what we do with the antithrombotics. There are patients who have serious bleedings, even intracranial bleeding. So yes, we have to accept a trade-off, a balance, as we said. So this is what trials are made for. So we do trials in order to see on a large scale whether the downsides are more important than the potential benefits. And look at these benefits. And my question to you would be, what are we doing to tackle these outcomes? Because I'm not sure that we have found a solution for microvascular obstruction, for intramyocardial hemorrhage, and there is an increase in awareness that this is very important. The infarct size, the ejection fraction, how many therapies have failed in this field? And it's this crucial in order to improve the clinical outcomes, because these are the typical surrogate endpoints, which in the end are the cause of the bad outcomes that we see in terms of recurrence, new myocardial infarction, death, etc. So,
stop.
Please.
This is again association. So IL-6 is associated with microvascular obstruction and is associated with intramyocardial hemorrhage. It doesn't say that inhibiting interleukin-6 will help you.
Oh, definitely. No, I totally share that. But association are really the premise, the basis to see whether interrupting this vicious cycle, you can have an effect. And again, this is what trials are made for. But again, I see many hints that this is a story that makes sense. And in this case, you are absolutely right. These are patients. Again, this is STEMI. And what they saw is that those with an elevated interleukin-6 actually have more likely microvascular obstruction, intramyocardial hemorrhage, and worse ejection fraction. So again, I very much appreciate what you say, because obviously you could have these bad effects in patients who are sick, and by the way, they have higher levels of interleukin-6. That's absolutely well taken, obviously. But still, you see, we started from animals, we are going to patients, we are going to myocardial infarction patients, and still the story, in my mind, resonates. Now, the question of the safety. So that's very important, and we cannot dismiss that, especially in patients and in general, but also in those with myocardial infarction. There are data from phase 2 studies of anti-inflammatory drugs. Non-STEMI, so this study was powered just to detect differences in CRP levels and in troponins, and they found that when you use tocilizumab, which is a drug against interleukin-6, and you compare with placebo, you decrease CRP, you decrease troponins. Okay, this is phase 2. It's not so exciting in a way. But these studies are also the only things we have to demonstrate safety, because, of course, they collect a proper number of patients, but not they are not adequately powered for that. But, you know, if in these studies you already see safety concerns, these studies are stopped and there is no phase 3. So that's very important to know. And if you look at STEMI, a SAIL-MI is another study published in the European Heart Journal. Again, tocilizumab versus placebo, let's say about 200 patients. So again, not a big number, but no safety concerns. That's very important.
Safety in 200 patients, come on.
Yes, I said that. But again, it's a concept which is alive. So it's not dead because there were, liver enzymes elevations and things like that. So again, this encourages us to go to the next step, in a way.
Yeah, but the next step, I think this illustrates what next steps are. Sometimes you have a very nice idea, you have a nice boat, you launch it, and then something utterly goes wrong because you have not thought about something. I think there was a small leakage here.
You're tough.
Yeah.
All right.
So there was a small leakage here where I think the designers didn't think properly of. So in my opinion, there is limited evidence. It's coming mainly from small-scale studies. There are potential complications arising, especially in the healing phase. Increased risk of infections, I think that's a true possibility. And so the implementation in acute settings, in my opinion, is challenging. So for me, you can only convince me when you do a proper trial. The proof of the pudding is in the long-term eating. If you wanna have it your way, prove it to me in the long-term eating.
Okay, I accept the challenge, and I actually share what you said, that in order to be convinced, you need to see replication and large numbers, of course. We like to see these important studies, especially when they are successful, but there is a lot to learn also from the neutral studies. So the point I wanted to make today, essentially, all the things you have said being acknowledged 100%, is that if you look at the optimistic side of the story, well, we have to admit that the background is sobering, because 10% of patients with MI still have a recurrent event. So we cannot accept that we have done, there is nothing to improve because we have a short door-to-balloon time, we do revascularization, we have networks, and we have antithrombotic medications and maybe other antithrombotic medications in the future. So we as doctors, as scientists, we have really the impetus and the need to do something else in order to zero this 10%. Zero is impossible. I know, it looks like impossible, but we have to tend in that direction. Otherwise, of course, there is no reason for science and also for investment, like, of course, companies do. The good news, and maybe you will be happy with this at the very end, is that the trial has started. So there has been a kickoff in the United States. There will be a kickoff in Europe very soon. In Asia, it's really a global study. Roxana Meran is the PI of the Artemis study, together with Adrian Hernandez from Duke. Novo Nordisk, of course, is supporting this study, and I will spend 1 minute on the design because I think this is a headline for many of you.
I think it's the first time you guys are seeing this, isn't it? Yeah.
Yeah.
So take them through it.
Let's say in the checklist of the quality things in a trial, many are green because it's randomized, it's parallel group, it's double blind, it's placebo control, and the outcome is a cardiovascular outcome, a composite endpoint. So this is what you want to see. Then the number of patients, 10,000 patients, means that finally it's not 200. We will see if infections are increased, if cancer, whatever, things that are not really emerging from the literature, but are a concern. That's for sure. So we need to show that this doesn't affect the our patients, but at the same time, we're interested in the primary outcome, which is an ischemic endpoint. So these patients will all have type 1 MI, so the MI with the atherosclerosis. Patients with MINOCA, maybe we can discuss, are not in this basket. And they will also have enrichment criteria, and they will receive a loading dose of ziltivekimab or placebo, and then a maintenance dose. And the idea is to tackle really those 3-4 days at the very beginning, as I show you. So the drug will be given within 36 hours from STEMI and within 48 hours from non-STEMI. And you can see that the trial objective is to demonstrate the superiority of the loading dose of ziltivekimab versus placebo, followed by the maintenance dose once monthly. And both will be added to the standard of care. So this is something on top of what we already do, not as a replacement. And MACE will be the primary endpoint with in patients who have angiographic evidence of thrombosis in the arteries. So this is the logical next step. Maybe we can agree. And of course, I'm happy to discuss with you.
Amici, you convinced me. Let's do the trial.
But isn't that exactly what we all think about when they're coming up to us and saying, oh, inflammation is important? We need to look at both sides of every equation. We're all caring for patients. We need to understand the kinds of risks that we take, the balance of some of the untoward effects, and moving ahead with a prospective, large-scale, powered, randomized, double-blind, placebo-controlled trial when you are embarking on such an innovative pathway. So I think, to me, this really is kudos to Novo Nordisk for actually really going forward with this in a very, very big way. Who wants to be an investigator? Who wants to come in? Anybody who wants to come in, we really, really want to hear from you. We're very excited. I want your questions. We have a few minutes now for Q&A. But before we get there, let's ask the first question. This is what Davide wants to know. Is
I'm not
IL-6
interested in the answer anymore.
a viable target in the acute setting? Did we convince you that this could be a viable target?
Not sure. No, but 96 was too much. I think the starting point was...
I know, I think 3 people answered. No, I don't know.
Okay, improvement.
Looks like you got an improvement, and so he was convincing.
It's convincing.
Thank you.
That's really good. I mean, I
10,000
think the purpose of this kind of dialogue is something we all need to look for whenever we're given a new therapy, to see the both sides. How does it go? How do we really, really evaluate this? And this is how we design studies. And I think this is really, really great. And also for all of us as interventionalists, you know, we care about science. We probably do more clinical trials than any other subspecialty of cardiology. And we're all excited about the science behind it. And here is novel therapies that's going to be hopefully part and parcel of what we do in conjunction with our intervention, to make that intervention durable, that patient free of recurrent events, if at all possible. It's a hypothesis that's actually going to get tested prospectively. We're very, very excited about this. We are across the globe and looking forward to launching this as early as next June, I believe, this June. Yeah. Coming up with our first patient. So in the next 20 minutes, guys, we get to have a little bit of conversation. And I want to make sure you have this QR scan. Ask me anything. It really is fine. We really want to have all of your questions answered. We have an anonymous person asking a question. Is it really viable to consider initiating another medication in the acute setting post-MI? Data has not been encouraging, like Impact MI. Like, this is going to fail. Why are you making us go through this? What do you think?
Dear Anonymous, yes, we can accept. I mean, we can accept, yes, but again, it's a pessimistic view, no? So if this is valid for MI, it's valid for anything. Why should we need another TAVI? Why should we need another technique for a bifurcation? Well, it's inherent in the concept of trials to fail. Many trials fail. And again, for me, failure is not the right word, because they teach something to be changed for the next trial. So I cannot accept the principle that we should not do something, being able to do it thanks to the support, of course, because we are not able to do it alone, simply because the question is useless. It's very true that the stakes are very high. So, of course, the investment is important, not just industrial investment, but patients, resources, doctors, etc. So we should tackle really relevant questions. But for me, the inflammation is the next big thing. We have already a positive trial. Don't forget canakinumab. So I was really disappointed that there was no.
Yeah, I was very excited about CANTOS. I think that was one of the first trials that actually was proof of the pudding, honestly, because the reduction of MACE was significant, 16% reduction. That's what statins did, you know, IMPROVE-IT did that over like a 12-year period. It was about 15% reduction. So you need to understand that was a really positive study, and with an IL-1, and knowing in a post hoc analysis that it was the patients who had the IL-6 levels lower who benefited most with reduction of MACE, makes me feel very, very interested in this trial and why I wanted to embark on it. But there is a very good question. Maybe this is to me. Residual inflammation where? Like, what's that about? And is it the vessel wall? Is it the perivascular tissue or the visceral adipose tissue? What a great question. You know that there's a lot of work now that's being done with understanding this whole cardiometabolic pathway of understanding what's going on. Is intra-abdominal obesity, or what we would call adipose tissue deposition, associated with inflammation? Probably yes. Probably yes. But is it the perivascular? We don't know all of those details. We know that there is a very important association, but the causality is unknown. What we do know is that when high sensitivity C-reactive protein is high and remains high, and that this patient continues to have chronic inflammation, they end up having issues with their major adverse cardiovascular events. That is an association. Is it causal? I mean, it's a biomarker. I don't know where the inflammation is. Maybe in different phenotypes, it's different places. Maybe some people are having it around the pericardium. I have no idea. Pericardial fat, or is there is there white blood cells associated with periadventitial fat? You know that Professor Antoniadis over at Oxford is studying hundreds of thousands of scans of people looking at inflammation in the perivascular, periadventitial fat tissue and inflammation associated with it. So it could very well be there. So that's a really good question. What do you think, Wouter?
I think the inflammation probably is everywhere. The inflammation is a general thing. It starts in the liver to a certain extent, but then it inflames your vessel walls. But in between is the blood, and in the blood there's a lot of cells. And I like to do preclinical research as well. And we recently did research in what is happening in inflammation with your lymphocytes inside the blood. And then you can clearly see that a number of these cells are already in a clearly pro-inflamed state, probably interacting with your vessel wall, making your vessel wall diseased. So I don't think there is one place of inflammation. Probably the inflammation is everywhere, from the liver to the blood cells. And it's actually what Virkov already said. So you're as good as your blood vessels, but it's in the surrounding, it's in the blood, it's in the vessel wall. And I think there's room for improvement. That, as I told you, I've done more than 10,000 PCIs, and my ultimate goal is actually to stay in bed during nighttime. So I really do hope that we can offer something additional.
Yeah, absolutely. So we talk about enrichment criteria, and they're asking what are those specifically. Obviously, patients with multivessel disease, those patients with diabetes, chronic kidney disease. These are enrichment criteria, and then they're all listed. Once you become part of the protocol, and of course the trial design will get published hopefully very, very soon, where you'll learn every little detail about our protocol. But at the moment, we are really, really looking forward to starting our very, very first patient enrolled. The truth is that the STEMI patients as a whole and non-STEMI patients who come in are going to have we don't need to measure their C-reactive protein right then and there, although these things are going to be looked at and the biomarkers will be measured. But I think if you can imagine, they're going to most likely have an elevated C-reactive protein. It's an acute phase reactant that often is elevated in STEMI and non-STEMI patients. So that wouldn't be your enrichment criteria, or you don't have to get that in order to get in. Any additions? Did I forget anything?
No, maybe we can say that if you want to see the protocol before the publication of the rationale and design, you can go to clinicaltrials.gov. It's already available. And also, maybe I'm interested in your reactions on the mix of STEMI and non-STEMI in a trial like that. Is it a risk for the trial, or is it what we want to make the results generalizable once the trial is possible?
Yeah, I mean, I think, the idea is to have acute MI patients. We know that, and we're going to have a stratification of STEMI and non-STEMI, so we get equal in both arms. And I think it's very important to have enough data. It's all acute MI. We really are not doing well in all of acute MI. It's not just in STEMI or non-STEMI. In fact, some of the non-STEMI patients do even worse because they have all these enrichment factors give them chronic inflammation and a constant return and recurrent events extremely high. They're a little bit older and they have a lot of events. And so if we could make an impact there, it could be really, really life-saving for some of these. And I think it's incredibly important. One of the questions that I think is very interesting is, will you allow colchicine in Artemis? And obviously that wouldn't make sense, right? I mean, we're looking at IL-6 inhibition. We don't want to start mixing different drugs. And so, yes, you're correct in that colchicine, if you're wanting to use colchicine, that wouldn't be a patient that we would want. And I want to make sure.
But for the rest, almost everything is allowed.
Yeah, and the truth is
all lipid-lowering compounds are allowed. And,
everything, and the highest and high intensity. We want the best care for all of the patients, as if you would be doing right now. The only difference here is half of the patients will receive IL-6 inhibition with ziltivekimab acutely with a loading dose and chronically during follow-up, and half would get placebo injections. Any questions there? Yeah, good. Okay, so the other one is, should we expect to have more effect on reducing post-MI remodeling, like preventing heart failure? And by the way, and future events and also recurrent events. Obviously, that's the big, and we do have an endpoint there that is enriched with heart failure hospitalizations. So there's no question we're going to look at that. The end game, and patients survive and then they end up with heart failure. If the remodeling could be switched, if everything you said is going to work, that is the holy grail, isn't it? We've never seen that happen. And I often worry about this microvascular obstruction that we're all watching in our patients when in post, in STEMI when there's clot, and you're thinking, oh, it's all distal embolization, but actually some of it is periadventitial edema from the ischemia and the injury zone, where we do have microvascular obstruction, whether it's with clot or edema. We know when MRI studies show us edema acutely after STEMI, and intramyocardial hemorrhage as well as an important area. If you could imagine that stopping this cascade could reverse some of this, it could be really, really interesting. Any additional thoughts about that for you guys?
It's a challenging thing, that's for sure, but it's not impossible, but it's also far from certain. But that's why we do the trials.
That's right. Exactly. So we have more. Thank you for all these great questions. Anonymous wants to know, IL-6 prevents plaque rupture, stabilize plaque, give us more confidence with long-term use in high ischemic risk, like polyvascular Pegasus patient. Does it prevent plaque rupture? Does it stabilize plaque? That is a great question that I'm hoping Novo Nordisk will answer, because if this works, don't you think people want to know what was the mechanism?
Exactly. No, I think that what we are seeing with the incredible drugs that are on the market, we first see the results of the cardiovascular outcome trial and then the mode of action studies, because research is going so fast that you have incredible monoclonal antibodies, for example. It's not just this one, but others. And then you have to understand why, for example, semaglutide decreases cardiovascular event even before the weight loss. No?
Yeah.
So there is a lot that you don't understand. There is a cardio-metabolism that explains many of the things, but then we have to be humble and admit that many of these processes are far from being unclear. But in the end, what we want is to reduce cardiovascular events. So if this works at an acceptable safety price, I think then we have all the time to understand why this benefit was there. But in the end, we want to reduce mortality, myocardial infarction, recurrent events.
So non-culprit lesions, would you be convinced if those plaques got stabilized, reversed, like Pac-Man MI?
Yeah, why not? And I think also the question was about the Pegasus-like people, that they have polyvascular disease. And I think those people are especially, first, of very high risk, but they have also very often a very pro-inflammatory profile. So I think we can just do more than only the acute situation if we're a little bit lucky. So also in the long run, we can do a lot of plaque stabilization and preventing MIs on the long run. And not only MIs, but perhaps also peripheral disease or whatever.
And we were taught at the university that the plaque rupture happens because the metalloproteinases, which are increasing inflammation, rupture the shoulder of the teacup. No? So if this is true, an anti-inflammatory drug may work in that setting also. Mm-hmm.
So we have a great question from Dr. Matson, Jasmine Matson. You're in there somewhere. Oh, hello, Jasmine. Thank you. And your question is, we all talk about timing of anti-inflammatory therapy and the early potential. Oh, don't take it away. I was reading it. Deleterious effect. Can you give that back? What is the idea was, what's the timing of intervention? Why is that so very important? What should it be? And is the what about, we're doing PCI immediately, and we saw that curve, so there's that inflammation, and then after PCI, it even goes even higher because of the injury that we're causing in the vessel. So what's the timing? Why is that so important, and why should we go after that acute phase?
Yeah, let's say this generated a lot of discussion in the steering and executive board of this trial. As you can imagine, you have to find a compromise between the practicality of the study, because ideally you would like to give this really on the table, but then of course this would make things not feasible. So you have to think of a window where you may expect the maximal effect. And I explain, and we showed this cartoon, that the first 3-4 days are really the key ones for the acute burst. It's a peak like that of troponins, but of course translated for inflammation, and then there is a decrease. But there is a feeling that the first hours are those that will affect the remodeling. So that's why 36 hours after STEMI, 48 hours after non-STEMI, because if we start too late, probably this is too late.
Yeah, perhaps you should also not start too early, but as we discussed, this seems to be the reasonable window. By the way, of course, this is not the first discussion we had on this topic. Remember when we started the statins, first you had to wait for a year, and then probably 6 months after your MI was okay, and then we had a very brave trial that we were starting statins after your MI within 3 months, because we were actually afraid to interfere with scar formation, which did not appear to be any problem whatsoever, and now we start the same day, or even on the emergency department, we give your statin already.
We give the statins in the ER at our institution. So Uta, this is for you. What's causing the inflammation in the first place? Is it our bad food? What is it? I mean, we don't know exactly. It's different things in different people, right? But what do you think?
So probably it's a lot of things. So for bad food is for sure, because if you have a bad diet, we have already shown that your T cells in your bloodstream have a pro-inflammatory profile. So, but it's also probably there is also the realm of infections that give you CRP rises, which is probably also associated with a bad prognosis. It's probably not one thing. On average,
oxidized LDL.
Yeah. So on average, it's known that our Western lifestyle is probably a pro-inflammatory thing. It's almost impossible if your LDL cholesterol is really, really, really low to get atherosclerosis, despite having infections. We did a huge study in Africa where their diet was composed of some kind of corn porridge. They had high inflammatory profiles, but extremely low cholesterols, and they had almost no atherosclerosis whatsoever, no events. So, but that phenotype does not exist anymore in our surroundings. We are all part of this pro-inflammatory environment. So probably pro-inflammation is everywhere.
So one other nice question is from Anonymous.
Are there 3 anonymous?
There are a lot of anonymous people. There are different people, yeah. But microvascular obstruction, a major contributor to poor outcomes. We know that is one of those, poor flow, when you don't get a good blush, all those things that we've been watching. And then is IL-6 associated with that? I don't know that there has been a good study to look at the IL-6 levels and microvascular obstruction. So we don't know that, but the idea that we could reduce inflammation, reduce periadventitial edema, and improve microvascular obstruction is an important one, and a nice study to do. Mechanistic studies are going to be very important in this study. So I think that's sort of the reason why we're thinking about this, because these are the areas that we haven't been able to tackle. And looking at another pathophysiological mechanism and going after it could be great. And in that last minute that we have left, I'll just quickly answer these questions. Is there going to be some heterogeneous profiles with the enrichment criteria? Randomization is the greatest thing known to man. It takes care of all of these heterogeneity. So then it gets balanced. And the only reason we're stratifying with STEMI and non-STEMI is because some centers get more STEMIs and some centers get more non-STEMI, and we want to make sure that they're nicely equalized. But the truth is these heterogeneities get balanced out when you have a large-scale study. The last question is, the real question should be, is inflammation the next step to target if you want to improve patient care? Despite the drugs, we should be looking for accessible, safe drugs, but here we are at a bias conference talking about optimism. If you believe this was a biased conference, then I'm sorry, because we tried to be extremely balanced, looking at both sides of the equation. And I take that to heart, because we're here to talk about science and educate you about science. And we need to be optimistic, because pessimism will not work for us, especially interventional cardiologists. We're looking to improve and enhance patients' lives. And we know that there are certain mechanisms that we haven't gone. We just can't throw more antiplatelet, antithrombotic drugs at these patients. We have limited that stacking therapies. In that level, we need to go beyond antiplatelet therapies. And we've already really exhausted those pathways, and we look forward to novel therapeutics that could bring us forward. And I want to thank you all for being here. And very, very important. It's important for you to complete this evaluation, please, through the QR code. I hope you learned and that you're walking away a lot more informed about the inflammatory pathways and the future of what's coming for our patients with an acute myocardial infarction. Thank you so much for spending your afternoon with us. And thank you to the two of you for your wonderful, lively debate.